Section 03 focuses on VF and pulseless ventricular tachycardia, which are the primary shockable rhythms encountered during advanced cardiac life support. Ventricular fibrillation, or VF, is a state where the heart's electrical system becomes chaotic and disorganized, causing the ventricles to quiver uselessly rather than contracting. Pulseless ventricular tachycardia, or PVT, involves organized electrical activity, but the rate is so excessively fast that the heart cannot fill with blood, resulting in no detectable pulse. The critical action for both rhythms is immediate defibrillation to reset the heart's electrical state. Recognizing these rhythms quickly is essential because every minute without defibrillation significantly decreases the chances of a successful resuscitation. We must act decisively when these patterns appear on the monitor. In Section 3.1, we examine the shockable rhythms in detail. First, VF is characterized by disorganized electrical activity, where the heart simply quivers and fails to circulate blood. Second, pulseless VT is defined as organized electrical activity, where the heart beats too fast to pump blood effectively, leading to a pulseless state. The mandatory action for these rhythms is immediate defibrillation, which is the only way to stop the lethal arrhythmia and allow a normal rhythm to return. This intervention must be prioritized over all other tasks once the rhythm is identified. Providing a shock as soon as the defibrillator is charged gives the patient the best possible chance for a return of spontaneous circulation. Section 3.2 details the defibrillation protocol used during resuscitation. The initial shock should be delivered at 200 joules if using a biphasic manual defibrillator, or 360 joules if using a monophasic device. Immediately after the shock, you must resume CPR by starting chest compressions without checking for a pulse or rhythm. This cycle of high-quality CPR must continue for exactly 2 minutes before the next rhythm check is performed. Minimizing interruptions in chest compressions during this phase is vital for maintaining coronary perfusion pressure. Following this protocol strictly ensures that the heart receives the maximum benefit from both the electrical therapy and manual circulation support. Section 3.3 covers the first-line drugs for VF and pulseless VT. Epinephrine is the primary vasopressor, administered as a 1 mg IV or IO dose every 3 to 5 minutes, usually starting after the second shock. Amiodarone is the preferred antiarrhythmic medication, given as a 300 mg bolus for the first dose and 150 mg for the second dose. Alternatively, lidocaine can be used if amiodarone is unavailable, with a first dose of 1 to 1.5 mg per kilogram. These medications work alongside defibrillation to increase the likelihood of successful rhythm conversion. Proper timing and dosing of these pharmacological agents are key components of the ACLS pulseless arrest algorithm. Section 3.4 addresses the management of refractory VF. Refractory VF is defined as ventricular fibrillation that persists despite the delivery of 3 or more shocks. Important considerations during this stage include checking for electrolyte imbalances, specifically abnormalities in potassium or magnesium levels. You must also ensure the person performing compressions is not fatigued, as high-quality CPR is essential. For advanced options, some clinical protocols consider double sequential defibrillation, which involves using 2 sets of pads and 2 machines to deliver shocks. Addressing the underlying causes of why the heart is not responding to standard treatment is the focus of managing these difficult cases. Section 3.5 explains post-shock physiology and why immediate action is required. The concept of the stun refers to how the shock stops all electrical activity, requiring a few moments for the SA node to recover and reestablish a functional rhythm. This leads to the question, why compressions? Because the heart is extremely weak and stunned immediately after a shock, manual compressions are necessary to support the heart until it can pump effectively on its own. Resuming CPR immediately provides the necessary blood flow to the brain and the heart muscle itself during this vulnerable transition period. Understanding this physiology reinforces why we never pause to check a pulse immediately after delivering a shock.